This is the Quiz Fix. I'm Cyril, that's Olivia. One true story per episode, one quiz at the end, because facts you tested on are facts you keep. Here we go. When people talk about major disasters in American history, the 1918 influenza pandemic should be near the top of the list. It spread around the world, infected a huge share of the population, and killed an estimated 675,000 people in the United States alone. That is an astonishing number, especially when you remember this happened in an era before antibiotics, before modern intensive care, and before flu vaccines existed.
Right, and the scale is hard to overstate. The pandemic infected an estimated 1/3 of the world's population. In the US, it hit in multiple waves, with the fall of 1918 being especially deadly. What makes the story even more interesting is that America's public health response was shaped by the science and institutions of the time, which were limited but not non-existent. Cities, state health boards, and federal agencies all tried to respond, though not always in coordinated ways.
And that lack of coordination mattered a lot. This was before the Centers for Disease Control and Prevention existed. The federal government had some public health capacity, but most response efforts were local or state-based. Public health officials had to make decisions quickly, often with incomplete information, and they were also fighting misinformation, panic, and ordinary human impatience. Sound familiar?
It does. But to understand the response, we should start with the pandemic itself. The 1918 influenza virus was highly contagious and unusually severe, especially for young adults. That pattern was one of the shocking features of the outbreak. Seasonal flu usually hits the very young and the very old hardest, but this pandemic produced a deadly wave among people in the prime of life.
And the timing was brutal. The United States was still involved in World War I, which meant crowded military camps, troop trains, barracks, and ship transports. Those conditions had spread the virus rapidly. The war also complicated public messaging, because authorities often wanted to maintain morale and avoid anything that might slow mobilization.
That's a crucial point. In several places, public officials downplayed the severity early on. Newspapers sometimes echoed reassuring language, and some leaders worried that telling the full truth would hurt wartime spirit. But once the virus tore through communities, the reality became impossible to ignore. Hospitals filled up, nurses were overwhelmed, and in some cities, even makeshift morgues were needed.
Let's talk about what public health officials actually did, because they did not simply sit still. Cities used non-pharmaceutical interventions, which is a fancy term for measures short of medicine. That included closing schools, theaters, dance halls, and churches in some places, banning large gatherings, isolating sick people, and promoting masks in certain cities. They were trying to reduce person-to-person spread.
And they were not all working from the same playbook. Some cities acted faster and more aggressively than others. There is strong historical evidence that places like St. Louis, which moved earlier to limit gatherings, experienced lower death rates than cities that delayed action, like Philadelphia, where officials allowed a huge parade and did not impose restrictions soon enough.
Philadelphia is one of the clearest examples of timing mattering. The city held a massive Liberty Lawn parade in late September 1918, even as influenza was already spreading. Soon after, cases exploded. By contrast, St. Louis moved quickly to close schools and public venues. It is one of the classic examples historians use to show that early public health intervention can reduce mortality.
Exactly. Now, to be fair, the comparison is not as simple as saying one city did everything right and another did everything wrong. Different cities had different population densities, different transit patterns, and different local conditions. But the broad pattern is strong enough that epidemiologists and historians still cite it. Early action saved lives.
Mask use is another fascinating piece of the response. Several cities encouraged or required face coverings, especially in public spaces. The evidence at the time was limited, but officials believed masks could help reduce transmission. Compliance varied, and not everyone liked being told what to wear on their face. Public frustration led to the formation of the so-called anti-mask league in some places.
That's right. San Francisco is especially well known for its mask ordinance and the later anti-mask league. The debates were about liberty, effectiveness, and trust in government. Even then, public health was not just a medical issue. It was also a social and political one, involving personal behaviour, civic responsibility, and public confidence.
And the health communication piece was difficult. Officials had to explain that a disease spread by invisible droplets could require unpopular measures like closing schools or cancelling church services. They also had to convince people not to crowd hospitals unless necessary, because hospitals needed space and staff for the severely ill. Today we might call this risk communication, but back then it was often improvised through newspapers, posters, and public announcements.
The medical understanding of influenza was limited too. Scientists had not yet identified viruses the way we understand them now. In fact, some researchers believed the disease was caused by a bacterium, and they were still searching for the exact pathogen. That meant public health decisions were being made in a fog of incomplete science.
Yet even with limited science, they knew enough to understand that crowding and contact were dangerous. They also recognized that isolating the sick and disinfecting shared spaces could help, though the effectiveness of some cleaning measures was probably less important than reducing close contact. Public health practice often moved faster than laboratory science.
There were also major staffing problems. Many doctors and nurses were serving in the military, and civilian hospitals were stretched thin. Volunteer organisations, including the Red Cross, played an enormous role. In some places, ordinary citizens helped care for patients, deliver food, and bury the dead. The pandemic exposed how fragile local health systems could be.
And it was not just an urban story. Rural communities struggled too, though their experiences varied. Some were relatively isolated at first, which helped delay spread. But when the virus arrived, access to medical care could be even worse than in cities. In some communities, entire households were hit, leaving children without parents or relatives.
The demographic impact was devastating. The pandemic caused a dramatic drop in life expectancy in the United States for 1918. It also created long-term social and economic disruptions. Schools closed, businesses lost workers, and families were thrown into crisis. Many deaths occurred so quickly that people could not even arrange proper funerals in the usual way.
One thing that sometimes surprises people is that there was no single nationwide shutdown order. The American response was decentralized. Local public health boards often took the lead, and the Federal Public Health Service worked with them, but the country responded in a patchwork fashion. That meant policies could differ sharply from city to city, even within the same state.
And that patchwork reflected American governance more broadly. Public health powers were, and still are, heavily shaped by state and local authority. In 1918, that meant some places were able to experiment quickly, while others hesitated or stayed open too long. The result was uneven, but it gave later researchers valuable natural comparisons of different strategies.
Another challenge was that the pandemic came in waves. Just when communities thought the danger had passed, the virus returned. Some places relaxed restrictions too soon, only to face a second surge. That made decision-making incredibly hard. Officials had to balance public fatigue against the risk of renewed spread.
It's a reminder that public health is rarely a one-and-done effort. The 1918 response involved repeated decisions about when to close, when to reopen, and how to protect the vulnerable. There was no perfect solution. The best outcomes tended to come from a combination of early action, sustained caution, and clear communication.
And even when officials made good decisions, they were still dealing with a virus that moved fast. Influenza can spread before people feel very sick, which makes containment hard. That property of the disease helped fuel the pandemic and limited the effectiveness of some interventions.
Still, the evidence from 1918 shows that interventions made a difference. Historical studies comparing cities found that layered measures like school closures, bans on mass gatherings, and isolation policies could reduce the peak burden of disease. That is one reason the pandemic remains such an important case study in public health.
There's also a human side to this story that can get lost in the numbers. Families improvised care at home. Communities organized volunteer networks. Clergy, nurses, undertakers, and local officials all worked under extraordinary pressure. The public health response was not only about rules and institutions. It was also about people trying to protect one another with the tools they had.
And that human effort mattered, even when it could not stop the pandemic entirely. One of the enduring lessons of 1918 is that public health works best when people understand the reason for the measures and trust the institutions asking them to comply. Without trust, even sensible policies can face resistance.
So if we boil it down, America's public health response to the 1918 influenza pandemic was a mix of urgency, improvisation, and uneven coordination. Officials used the tools available to them: closures, isolation, masks, public messaging, and community support. Some cities moved quickly and saved lives. Others acted too late. The pandemic exposed the limits of early 20th century medicine, but it also showed that public health action could make a real difference.
And that's why historians and epidemiologists still study it. The 1918 pandemic is not just a tragic episode from the past. It's a reminder that in a fast-moving outbreak, timing matters, communication matters, and public health infrastructure matters. More than a century later, those lessons still resonate.
This episode of the Quiz Fix is brought to you by Fyrebox, Fyrebox, the smartest way to put your audience to the test. From lead gen quizzes to personality tests to training assessments, Fyrebox helps you launch beautiful, fully customizable quizzes in minutes. Thousands of marketers, teachers, and creators already use it to turn visitors into qualified leads. Build your first quiz free at fyrebox.com. Welcome back. You just heard the story. Now let's see what stuck. Coming up, a few quick questions straight from what we just covered, 4 options each. I'll give you a few seconds to think before each answer. Ready? Here we go. Question 1. About how many people did the 1918 influenza pandemic kill in the United States according to the script? A. 67,500. B. 675,000. C. 6.75 million. D. 1.3 million. The correct answer is B. 675,000. Question 2. Which city is used in the script as an example of early aggressive public health action that helped reduce deaths? A. New York, B. Philadelphia, C. St. Louis, D. San Francisco. The correct answer is C. St. Louis. Question 3. What major event in 1918 helped spread the influenza virus through crowded camps, trains, and transports? A. The Great Depression, B. World War I, C. The New Deal, D. The Korean War. The correct answer is B. World War I. Question 4. Which of the following was mentioned as a non-pharmaceutical intervention used during the pandemic? A. Antibiotics, B. Vaccination campaigns, C. Closing schools and theaters, D. Organ transplant procedures. The correct answer is C. Closing schools and theaters. Question 5. What was one key reason the 1918 public health response was uneven across the United States? A. There was a single nationwide shutdown order. B. The CDC directed all local responses. C. Most response efforts were local or state-based. D. No cities had any public health officials. The correct answer is C. Most response efforts were local or state-based. That's a wrap on this one. Thanks for sticking with us all the way through, quiz and all. If you liked it, hit subscribe so the next episode lands automatically. I'm Cyril, this was The Quiz Fix, and we'll be back soon with another true story worth knowing.